During this lecture, you will be able to understand the pathophysiology of fetal circulation, and you will be appreciating the difference between normal fetal circulation and postnatal circulation. If you know the normal, you will be able to identify the abnormal. And always, I'm stressing on the teamwork in the labor room. So in obstetric, you cannot work alone. You have to work as a team. You need to know about the normal fetal circulation. While in the uterus, the fetus receives oxygen from the mother through the placenta. There are various adaptations in the fetal circulating system, ensuring that most vital organs, like brain and heart, receive sufficient oxygenated blood. For example, there are shunts like the ductus arteriosus, the foramen ovale, that help direct the blood flow in the fetal heart to bypass the lung, since they are not functioning well in the womb. This adaptation gradually close or redirected after birth as the newborn starts breathing on its own. So it's fascinating how the fetal circulating system adapted to ensure oxygenation in utero. During pregnancy, the placenta acts as the main source of oxygen for the fetus, delivering oxygenated blood through the umbilical vein. The vein translated into the ductus venosus after leaving the placenta with a diameter about one-third that of the umbilical vein, narrowing the lumen of the ductus venosus, leading to the acceleration of the blood flow during increased pressure, with approximately 60% umbilical venous blood entering this pathway, while the remaining 40% enter the hepatic circulation. Remember that the majority of the blood in the ductus venosus, which is about 98%, will flow toward the left hepatic vein, combining with the oxygenated rich blood from the placenta. This blood mixture then passing through the foramen ovale into the left atrium, containing high oxygenated blood at around 65% oxygen saturation. From the left atrium, this oxygen-rich blood moving directly into the left ventricle and then into the ascending aorta, supplying vital organs such as the heart, muscles, and the brain. The blood flow from inferior vena cava and the right lobe of the liver flow together toward the right atrium, mixed with blood from the superior vena cava and coronary sinus to pass through the tricuspid valve into the right ventricle toward the pulmonary artery. Because the lung is not functioning in utero, high pulmonary vascular resistance, allowing 12 to 15% of the cardiac output to pass to the lung, while the flow to the lung with the rest of the cardiac output, around 88%, will flow directly to the ascending aorta through the ductus arteriosus, and this is lead to high nourishing of the brain with high oxygenated blood. Remember that the cardiac output of the fetus differs from the postpartum due to the presence of shunt in the fetal circulation. In the fetus, the right ventricle receives 65% of the cardiac output, while the left ventricle receives 35%. Therefore, the fetal cardiac output is calculated by combining the output from the left and right ventricle. Deoxygenated blood returning to the placenta via umbilical artery, which originated from the internal iliac artery near the bladder. Fetal oxygenation. Although the blood from the placenta via the umbilical vein carry oxygen with PO2 as high as 55 mm mercury, fetal circulation and compensatory mechanism ensuring high oxygenation of the fetal tissue. The fetal oxygenation depending on three important factors: fetal cardiac output, fetal hemoglobin concentration, and oxygen saturation. Remember that the fetal oxygenation is influenced by the following mechanism. During intrauterine development, the fetus exhibited a high cardiac output, with fetal heart rate typically ranging between 120 to 160 beats per minute. Additionally, the presence of fetal hemoglobin, which is having a high affinity for oxygen, and high hemoglobin concentration, more than 16 milligram per deciliter, collectively enhancing oxygen delivery to the fetal tissue. Another critical mechanism is fetal circulation, which ensures adequate oxygen supplying to the tissue. This circulation pattern, beginning with the liver receiving a high oxygenated blood directly from the umbilical vein. The ductus venosus then directs blood with a minimal mixture of the deoxygenated blood directly to the left side of the heart. And this process ensuring that the myocardium and the brain receiving the highest oxygenated blood via coronary and carotid artery, respectively. Control of fetal circulation. Circulating catecholamine exerting their effect by activating alpha and beta adrenergic receptor, which mature early in the gestational independent of the maturation of autonomic nervous system in the third trimester. The autonomic nervous system affecting the fetus through sympathetic parasympathetic pathway, influenced by the catecholamine, chemoreceptor, and baroreceptor. Ultimate contribution to high peripheral vascular resistance in the fetus. To be able to conduct fetal heart rate monitoring, we have to do either external fetal heart rate monitoring or internal fetal heart rate monitoring by fetal scalp electrode. The aim of conducting the cardiotocography is to detect early changes in the fetal circulation in the response to fetal hypoxemia or hypovolemia. Interpreting the fetal heart requires a minimum of 10 minutes. When we are interpreting the fetal heart rate, there is 4 features we have to concentrate on. Fetal heart rate baseline, baseline variability, acceleration, and deceleration. Baseline fetal heart rate. Baseline fetal heart rate is the heart rate range that occurring between contraction. Average fetal heart rate is between 110 and 160. It is the least sensitive measure of the fetal well-being, and persistent baseline above 160 considered to be tachycardia, where persistent baseline below 110 considered to be bradycardia. As we mentioned, fetal tachycardia is defined as persistent fetal heart rate baseline above 160 beats per minute. Several factors might affecting the fetal heart rate and cause fetal tachycardia. There is some maternal factor like increased temperature, external stimuli, medication. And there is some fetal factor like normal change in the fetal activity, tachyarrhythmia, and fetal hypoxia, or change in the placental blood flow, which might be reflecting fetal asphyxia or hypovolemia. Fetal bradycardia is defined as fetal heart rate baseline below 110. Fetal bradycardia can be caused by many factors. Some of it maternal, like maternal medication, or fetal, like persistent fecal tone, severe fetal asphyxia, and bradyarrhythmia. Thank you for your commitment to better obstetric care.